So, Michael, you'll be giving the talk?
Yeah, I'm gonna do the first portion, and then Dr. Brooke is doing the second portion.
All right. Um, would you feel more comfortable waiting for him, or would you want to start?
Yeah, let me just reach out to him real quick. I know Liz sent the email reminder. Sorry, yeah, we were in the wrong one, but maybe another minute. If not, I could just start talking.
All right. Well, Mike, while you're contacting him, I'll give you an introduction that I'm reading off the flyer. So this will be the Center for Global Surgery Works in Progress with special speakers today. Dr. Ben Brooke is the Chief of Vascular Surgery at the University of Utah and has been working on vascular surgery in Kigali, Rwanda. And Michael Oravic is a second-year med student at Geisinger. Um, and Michael, when you start, maybe you can tell us sort of your association with the University of Utah.
Sounds good.
But Michael's also been working on the vascular surgery project in Rwanda.
Yeah, so hopefully Dr. Brooke will be here soon. So I guess I'll just start. Yeah, so thank you for the introduction and thank you guys for having me. My name is Michael Orvik, and I'm a medical student at Geisinger, as mentioned, and I got involved in with the University of Utah actually because I was looking for more global health research and more things to do. And I have a background. I studied global health and global surgery at King's College London. And once I started medical school, I was really missing that, and it's something I think I want to do throughout my career. And I really liked what was happening at University of Utah with Dr. Jayaraman and Dr. Brooke. So I reached out, and then almost it's over a year later now that I'm around, and so really excited for all the multiple projects that we're doing together. So today I'll be talking about ongoing project between the University Teaching Hospital of Kigali and the University of Utah in regards to vascular surgery. And we did the first assessment in needs and barriers of delivering vascular surgical care in Rwanda. So global collaboration has significantly increased life expectancy in many low and middle income countries. Historically, the collaboration that has happened has focused on communicable diseases like HIV and malaria. And they're seeing great success. Life expectancies are significantly rising. However, with that life expectancy increase, we're seeing a higher prevalence of non-communicable diseases. And with that, we're seeing a lot more diseases that need to be handled through surgical operations. However, stagnation of surgical care has stagnated compared to other sectors in the healthcare fields. So multiple factors are responsible for the rise in non-communicable diseases on top of the increased age. What we're seeing is countries are adopting more westernized diet, a diet with more fat, and we're seeing greater socioeconomic disparities. Less people are going to the doctors, as well as increase in tobacco use and urbanization of countries where the people are walking more and generally leading unhealthier lifestyles than previous before. Vascular conditions are the most frequent cause of death attributed to non-communicable diseases in sub-Saharan Africa. 37% are due to cardiovascular cause, and then they account for 13% of all deaths. And right now, vascular surgery is a novel field with few developments in sub-Saharan Africa. So Rwanda is not immune to the epidemiological shifts in the aging population. They're seeing higher incidence and higher prevalence of many of these vascular conditions. And 44% of deaths in 2020 were due to non-communicable diseases. However, there are no fellowship-trained vascular surgeons based in Rwanda. Interim care is being provided by visiting vascular surgeons. I think there was around 10 or so when I was there this past summer. And there's an unknown prevalence of vascular conditions. The surgeons do not know how much of them they're seeing, how often they're seeing vascular conditions. So it's really quite a problem. Developing a training program in Rwanda would help to teach vascular surgical techniques to general surgeons, so that way they could fix any surgical diseases they might see, as well as improve patient care and outcomes. So in this project, we sought to provide the first exploration into the prevalence of vascular conditions in Rwanda. We also looked to survey surgical staff on their training and knowledge on vascular care, as well as identify barriers hindering the delivery of vascular care. So we decided to send out a survey, and we created the survey through Google Forms. We wanted it to be accessible to everyone and in a really non-time consuming way. So different domains of the survey, we looked at existing resources, the types of vascular conditions currently treated, as well as barriers to delivering vascular care in the current practice environment. The survey was administered to the 169 members of the Rwandan Surgical Society, and we did this through WhatsApp. Again, we just wanted as many eyes, as many surgeons to have their eyes on it as possible. And after talking with several different surgeons on the ground in Rwanda, we thought this was the best way to distribute the survey. So we received 22 responses, which was around 13% of the Rwandan Surgical Society. The respondents represented 4 different surgical specialties, the most being general surgery. 50% had no vascular surgical training at all, meaning in their residency, they didn't receive any training as managing conditions or even identifying certain conditions. And all the respondents indicated a high interest in vascular care, not only for their personal self, but also for the country of Rwanda and its healthcare system. So as far as prevalence of different diseases, varicose veins was listed the most. It was listed by 64% of the surgeons. Now, varicose veins might not be the most life-threatening condition, but they are clinically significant in Rwanda because varicose veins, surgeons are seeing them a lot, but no one knows how to fix them. You know, in many high-income countries, for America, for example, varicose veins are relatively not clinically significant. But in Rwanda, they are because, again, no trained surgeons that know how to fix them. Another one is trauma-related. 27% of vascular conditions seen by surgeons are trauma-related. And due to the care gap, a lot of the times what might be fixable or amendable in high-income countries leads to amputation in Rwanda. When we're classifying the cases seen, most are elective at 44%, but nearly 20% are urgent, and then 15% are emergent cases. The greatest barrier to vascular care in Rwanda was indicated to be training through and through. The next one was vascular surgery-specific consumables, anything related from OR equipment to identifying conditions. And as you can see here, there's a picture from the operating room. So when we asked respondents what resources were available at the hospital, over half of them said there were no resources. And then a few, like up to 20%, indicated basic equipment or vascular surgery specific consumables. So in summary, Rwandan surgeons commonly see vascular surgical conditions, and they know that they're seeing them, but sadly they have no way of treating them. And that is why training and education are recognized barriers to delivering vascular care in Rwanda.
All right. Thanks, Michael. Sorry I was a little late logging on. For some reason, my computer wasn't allowing me. I had to reboot it, but I appreciate Michael starting off, and you know, he's done some tremendous work just doing an initial needs assessment, you know, for this need to develop a vascular surgery training program in Rwanda. And so, you know, some of this information is kind of critical to deciding what the next steps are in terms of you know, education building, curriculum development, and whatnot. So, you know, I wanted just to kind of talk about you know, my involvement. So I got involved with you know, this project probably, you know, a little over a year ago. And when Suda approached me and said, you know, I've got some colleagues in Rwanda, I'm doing some projects, but, you know, there really is a need for vascular surgery, you know, training. You know, clearly there's, you know, kind of these models where people will go over and, you know, do cases for a week and then disappear. But, you know, really they need to have something that is sustainable for long-term, you know, care of their patients. And that involves, you know, training both the existing vascular surgery residents, but also ultimately starting a fellowship training program at the University Teaching Hospital, which is also known as CHUC. Do do you have control of these slides? Yeah. So so the person who Sue to connect me with is Dr. Faustin, who is the chief of surgery at Chuck. He's a plastic surgeon, but is somebody who really kind of understands all the nuances of all the different surgical specialties and recognize that this is something that if they wanted to, keep up and be able to, modernize their surgical system, they needed to have vascular surgery part of this training. So the goals that when he reached out to me were to help them develop a training curriculum for their general surgery residents. So essentially what we did is we looked at the training curriculum that we use for our existing general surgery residents at the University of Utah and modified some documents to be very specific to their own individual practice environment. So we worked on that. We kind of, did sort of an iterative process with some back and forth, but ultimately have a document now that they can use, for their trainees. And then, what we're trying to do is to try to start this curriculum by having some of our vascular surgeons travel over to Kigali and essentially work on setting up some 1 to 2 week workshops where we're focused on vascular surgery at probably 3 or 4 times during the year so that we can give them sort of a more intensive experience of both some surgical case training and some wet lab, but also some classroom didactics. The other thing that is part of this training module is that we recognize that we need to train some of the existing surgeons that are who are working at Chuck right now, who have expressed some interest in developing and learning vascular surgery techniques, but just have never had any formal training. So I traveled over to Kigali back in December and met several general surgeons that I met with, and they like the needs assessment showed that they already see patients with peripheral vascular disease, critical limb ischemia, the need for dialysis access, varicose veins or venous insufficiency, but they really don't know how to treat them. I mean, they're literally trying to Google how to do procedures, and things are just really not sustainable in terms of delivering adequate patient care. So we are, what our model was to try to identify these folks and travel over and actually work with them, closely to try to help develop their skills. And then finally, the last sort of component of this is that there are 2 surgeons that are Rwandan who identified and self-selected to gain additional training in vascular surgery outside their country. So there are actually 2 surgeons right now, one in Ethiopia and one in Egypt, who are in formalized vascular surgery training programs in these countries. And they're kind of staggered. So one is set to return to Kigali in 2026 and the other in 2027. But the thought being that once these surgeons return, they would need sort of assistance with building the programs, but also ultimately trying to develop a vascular surgery fellowship training program that they would be the ones to help lead. Just so a little bit of background too. So the training program that was developed in Ethiopia was developed by Gurma Tefera, who is a vascular surgeon who's at the University of Wisconsin, who is in charge of the American College of Surgeons HOPE initiative, which is their global surgery initiative. And he's been very involved in sort of some program building as well. We can go to the next slide. So the plan right now, if to develop a fellowship program, and clearly, there's a lot of things that need to happen before this would be able to get off the ground. But it's really to, once these surgeons are settled in, to try to identify, general surgeons that are currently being trained at Chuck and recruit them into this program. But set them up with the tools that would allow them to do more advanced, vascular surgery cases. Right now the facilities are pretty limited at their existing teaching hospital. I mean, they don't have any angiography suites. They don't have they have very rudimentary vascular instruments for doing cases. So what we've been doing is to try to, identify what we need to bring over, and hopefully we could, find some, some used equipment and whatnot, and take it over just for basic trays. They do have vascular ultrasonography. They do have vascular ultrasounds that can be used. They have a brand new CT scanner that can do CT angiography. So there are some more modern devices, but really the thing that's lacking is being able to do real-time fluoroscopy for doing hybrid cases, or a lot of what constitutes modern vascular surgery, by being able to do imaging is in combination with open vascular repair. We can go to the next slide. So one of the things that is on the horizon, though, is there is a new teaching hospital being built in Kigali right now. They've been working on this, I guess, for about 2 years now, and they actually took me to visit the site, which I've shown here in this photo. So, they say that it's going to be completed sometime in the next 2 years, but as things go, I mean, that could mean that it's really more like 5 years. But this will be a modern facility with fluoroscopy imaging and modern sort of ORs that would be to enable us to do more modern, vascular surgery as well as cardiothoracic procedures. So that is something that is on the horizon. Interestingly enough, when I went to visit this hospital, which again is basically being framed right now, on the fence outside the hospital, it said that it's being funded by the Chinese government. So clearly the Chinese are trying to get involved in getting their hands in the pots in a lot of things in East Africa, but helping them build their modern hospital is one of the ways that they're doing that, which was, I thought, pretty interesting. We can go to the next slide. So just to also give some background, so right now, there are groups from the U.S. that are going to Rwanda as part of the American College of Surgeons Hope Initiative. And they're primarily going to the King Faisal Hospital, which is the private hospital. They've got a big foundation that is able to basically pay for, American surgeons to go to Rwanda and put them up in, hotels or, housing, and pay for their airfare and all that. But it's, again, when I met with Dr. Faustin, he said, this is a model that allows, them to have support from, colleagues in America. But the problem is that they're not really focused on helping to build the education and helping to train some of the surgeons. So that's why he was asking us to get involved in this program, is that he really wants us to build a more sustainable training program within their hospital, sort of the public teaching hospital, Chuck. They don't have necessarily the same resources that King Faisal has. So even though there is like kind of some other initiatives going on in Rwanda and in Kigali, and primarily through Dr. DeFer's, initiatives, it's not necessarily in line with what they're trying to build at the public teaching hospital. And so, we're trying to, kind of work the politics right now to, maybe work with the ACS Hope group, but also, kind of be also responsive to what we're being told from the, the people at, the teaching hospital about what their needs are in terms of training. So, so I've been meeting with ACS Project Hope folks as well, and we're just trying to see how we can synergize our efforts, so we're not overlapping things, but actually doing things in concert. And part of that is that they are doing some webinars every other month to basically present topics to people who are interested in Rwanda. And so that's something that we might also participate in as well. You go to the next slide. So there's a lot of barriers and challenges with starting a project like this and trying to recognize the needs that have been identified in terms of clinical conditions and things, but also understanding what are we able to do in terms of vascular surgery and within the facilities that are currently there, but also recognizing that there might be some modernization that occurs. So, I mean, our modern vascular, OR suite looks like, this picture, which is obviously what they don't have right now, but, can we still train them to do cases, you know, with the thought that, ultimately there might be a day where they do have more modern facilities. Navigating the politics is also part of this process. There's a lot of competing interests. There's a lot of people who are, have been going to Rwanda over many, many years and trying to set up programs there, but have not necessarily been successful. And so understanding where, the pitfalls are, where they've been successful, where, the things that we need to address, and trying to sustain this momentum over many years. That's really kind of where we're trying to figure out how to make this work. Within my division, we have, there's 4 of us that are actually interested in, traveling to Rwanda on a regular basis and trying to make this work. But, we also have to balance that with, the interest of, maintaining our clinical productivity here at the University of Utah and making sure that we're not, leaving gaps in our care as we're going over and trying to do some of these things. And then finally, with any of these programs, I mean, it's the trying to find the financial support for doing these things, both, to support, our faculty when they go over and travel. And, we need to, recognize that it's not cheap to get over to Africa and to, stay there for maybe weeks at a time. And so, how do we make that happen? And, looking both within, institutional resources, but also are there foundations or other, things that we can tap into for money to help, make this happen and build this. So these are all the things that, I'm trying to wrestle with right now, and, interested to get people's, feedback and input on, what's worked in other environments and what might be able to make this a successful, endeavor over many years to come. So that's the last I can go on this one. So, happy to answer any questions, both me or Michael. I mean, Michael spent, some time, living over there and really gets, understands the environment as well. So we're happy to answer any questions or get feedback.
Thank you, Ben and Michael. I have a few questions. Can I just ask Michael one? So Mike, you gave some data on prevalence of vascular diseases, and how accurate do you think those figures are?
Yeah, so I think they're probably underreported, truthfully. We're just asking the surgeons how often are they seeing them in a question-based format, where it was like categorical. When we asked, for example, how many procedures do you do a month? We put it in 0 to 10, 10 to 20, 30 plus, or stuff like that. But as far as how accurate I think our prevalence data is, I do believe they're probably underreported. From what I understand, and Dr. Brooks could probably talk on this too, is oftentimes if the surgeons are operating on one condition, they might mentally recognize a vascular condition, but they never document it, and they probably forget about it, to my understanding. But yeah, I believe they're probably underreported.
Great. And Ben, you had a lot of good questions on, starting a program and progressing it. May not be anyone in the world more knowledgeable about that than Catherine DeVries, who's
She's got her hand up. So yeah, Dr. DeVries.
Yeah, Catherine, I'm thinking, what advice would you have for Ben and Michael?
Well, I had a thought, and maybe you've already communicated with him, but here at the University of Utah in neurosurgery department, Carol Budahowski is doing endovascular neurosurgery in Tanzania. And as I've communicated with him about it, there are a lot of common issues for doing this kind of surgery in that region. And some of it has to do with consumables, and some of it has to do with infrastructure. But in the COSAXA region, which is the College of Surgeons of East Central and Southern Africa, there are sort of a network of people who are doing similar types of surgery with similar needs, infrastructural, consumable, and then education in general. Had you considered maybe sort of teaming up and looking at common ways to transmit education in a region rather than a specific facility, using COSEXA, for example, as a platform?
I have not considered that, but that's an interesting thought. I know that Faustin is part of COSEXA, and when I went to visit in December, he had just returned from that conference that was in, I think, Zimbabwe this year. But I know that's kind of there's a lot of good sort of consensus building, and a lot of things that are done regionally are done through that organization. So I haven't gone to that sort of conference or meeting or know that much about it, but that's a great thought.
Yeah, I bring it up because we actually did put on a conference with COSEXA just before you met with Faustin, I believe.
Yeah.
He was there participating in our course, which had to do with multidisciplinary approaches to pediatric urology. So he's a guy who wears many hats, including reconstructive surgery, which is how he happened to be part of ours. But at COSEXA, you might have an opportunity to reach not just the Rwandan people, but also the other people in the region, and then possibly even have a session at the main meeting about common problems with some of these infrastructural and consumable issues that are would be useful information, not just to vascular, but to neurosurgery, maybe even urology. I mean, everybody uses guide wires and, some similar kinds of things. And what those supply chains are problems that affect everybody in the region and limit their ability to do it. So it's not sufficient to just know how to do stuff. If you can't do it because you can't access what you need,
Yeah.
maybe on a regional basis, some of these problems can be solved so that it doesn't have to be hospital by hospital, institution by institution, or even country by country.
Yeah. Well, a lot of it, at least in vascular surgery, is having access to vascular grafts. So I know the people that go over say, you've got to basically find all the expired products and just bring it with you. I mean, but that's not always like a sustainable way of doing it. Like, but that everybody I've taught, because there's a vascular surgeon who's going to Tanzania, who's at UCSF, and like that's the same problem they're running into. The people that are part of this ACS Hope group, which I mean, they're surgeons from all over the U.S., but they're when they go to Rwanda or Ethiopia, they said, yeah, you've got to bring Fogarty balloons, you've got to bring grafts, you've got to bring all this stuff, and I'm like, I don't know how you can do that on a regular basis,
Yeah, well, I have been managing those kinds of problems for the last like 30 something years, for the reason that we need all that stuff for urology too.
Yeah.
For kind of a long time, we stockpiled it and kept track of all the various line items, of which there are many, and then packed them all up in suitcases and bins and took them wherever we went. But I think when you're talking about sustainability, then you have to start talking about, well, what companies manufacture this stuff? What are their potential business interests in the region? Who are the representatives? And can they see value in supplying more than just one hospital, so that they would invest there? So it becomes sort of a larger problem that solves a lot of smaller problems. But we surgeons very often don't think about that, because we just want to go in there and have it magically like arrive. And the supply chain is somebody else's problem. So, but I do think that if there are enough people doing similar kinds of work, then whoever manufactures and supplies the grafts and all of the other stuff um, would see an opportunity to build that, so that it's
Right.
not a recurring problem for visiting surgeons to manage.
Right, right. Well, and there's money. I mean, I mean, you look at this hospital that's being built. I mean, there's an influx of money. I mean, sometimes from foreign governments, but there is money, and that money can also be used for the consumables, the things that need to sustain programs within these facilities. Yeah,
Well, I will say this about the Chinese, that's not what they do. They like to build the building and then leave it.
yeah,
So, uh, but the supply chain a lot of times comes out of South Africa,
yeah,
things like suture and stuff like that. But sometimes from India or Pakistan. But helping to identify those things, at least developing a list of what would be needed and seeing who else in the region also needs that. And then perhaps, leave it to or help the regional folks um, push to get it, on a consortium basis. Sometimes I think that that is as important as teaching the technical procedures.
right. Yeah, I agree. I agree. I think it's a critical barrier to sustaining these program building activities.
So, well, think about COSAXA. It happens
Right.
every December, and it's a good place to meet and talk to like-minded people who are trying to solve those problems.
Right.
And Ben, I emailed you the name of the neurosurgeon here who Catherine mentioned is doing the endovascular work
Okay.
in Tanzania. Yeah, he may have information that could be helpful to you.
Okay. Yeah, that's good. Good to know. I didn't realize that. Anyway, I mean, I talked to Jeremy Myers. I know that he's doing some, reconstructive work in the same hospital, and so I talked to him before going there, and kind of got some perspective from, just his experience over many years. So
Yeah, and I know the Comfort Noche Hospital in Ghana, there is someone there who they call a vascular surgeon. I think most of her practice is still general surgery, but I'll ask her what she does for grafts.
yeah. Well, what I recognized when I went there was that probably the easiest thing to start by doing was, I went and visited their dialysis unit. They've got a list of, 50 plus patients that need AV fistulas. Nobody knows how to do an AV fistula. I mean, to us, that's the most basic vascular procedure, but just being able to go over and work for a week with their general surgeons and teach them how to do, a simple AV anastomosis is, would help.
Yeah.
Because then you have somebody who knows how to do that and knows how to, just do kind of the simple workup for those patients and the follow-up care. I think that's kind of a starting point. That's where we were planning on starting.
Yeah, and maybe Catherine may have a different idea, but I can just from my own experience in Ghana, it was made a much better relationship when I asked them what I could do to help them. For the first couple, I went over and I said, "This is what you guys need, sort of for procedures."
Yeah.
And the interest was okay. And then we sort of said, "What would you like to learn?" the answer was not exactly what I expected, but then when we started working on those things, they had much more interest.
Right.
Um,
Yeah,
Well,
there are some interesting people in Rwanda who you may also want to meet, who are, have had a longstanding interest in global health, global surgery, who are newly in Rwanda. So it's that the network there is pretty big, and I'd be happy to introduce you to some of them if you are interested. You know,
yeah, absolutely. I mean, Suda had made a bunch of introductions to some different people. The the hospital that or the training college that Dr. Farmer set up. I met with some people there, Dr. Roy.
oh yeah,
Yeah. So I mean, I was able to meet with some people just outside of like the teaching hospital and got some perspective on just the kind of the local politics and environment, because that's that's part of it, is just understanding kind of like there's a lot of people that are trying to do things, but sometimes they're competing with each other. So
yeah. Well, Roy is a good person to know, and will offer great perspective from many angles.
yeah, yeah. No, he already has. So
Great. Well, thank you. Any other comments?
Yeah, I see Hafsa's question in the chat asking about if we're planning on doing a
Oh.
follow-up survey after the
Yes.
training. I think that would be great in a few years' time to just see all the work that we have done up to that point and how it's definitely affected Rwanda and Rwandan surgeons in a positive way, and then also see what further can be done. I think that'd be a great idea. Yeah, thank you.
Very good. All right. Anyone else? All right. Well, Michael and Ben, thank you both very much. That was great. All right, Michael, you gotta get to a surgery rotation soon.
Yeah, not until December, sadly.
Uh,
But
do an away rotation in vascular surgery at Utah next year.
yeah, sounds good.
you should, yeah.
Yeah.
Okay, well,
Yeah.
good. Well, thank you everyone for attending and participating. Thank you especially to Michael and Benjamin.
All right.
Yeah.
Thanks,
All right,
everyone.
Ben.
Thanks,
Thank
Brian.
you.
All right. Thanks,
Bye.
guys.
Bye.